состоянии.
Cardiac tumor are rare clinical entities that challenge our diagnostic acumen. Early recognition and diagnosis of a cardiac tumor by integration of clinical symptomatology and imaging findings could lead to appropriate management in a timely manner. Echocardiography is therefore a highly valuable tool in the assessment of cardiac masses and regarded as the first-line imaging modality. The aim of our presentation, it is crucial to always differentiate normal cardiac structures or anatomic variants as well as ultrasound artifacts from the pathologies to avoid inappropriate testing and unsuccessful surgical procedures. History, development, diagnosis of cardiac tumor is shown on this slide. And in 1968, Stattenberg used the first time echocardiography to diagnose cardiac tumors. On this slide, you can see the epidemiology of cardiac tumors. The next. It is continuous of previously slide, and you can see the anatomical structure, anatomical position of cardiac tumors in all the chambers of the heart. Primary tumors most commonly involve the endocardium, followed by myocardium and then epicardium. Metastatic involvement of heart is reserved then of primary tumors. Clinical characters of cardiac tumor included endocardium, myocardium, and epicardium pathology. You can see the location of cardiac tumors in every chamber of our heart. And when diagnosing heart tumors, there are 4 categories: systematic manifestation, embolism, cardiac impact, and metastasis. Cardiac manifestation. Primary tumors of the heart, particularly myxomas, often cause general symptoms such as fever, malaise, chills, weakness, and weight loss. Metastasis. Most malignant tumors of the heart are diagnosed at the advanced stage when systemic dissemination of malignant cells is already present. Embolism. Malignant primary tumors of the heart are often accompanied by embolism. Nearly every organ can be affected by a thrombus released from the surface of the sarcoma. This may lead to ischemia, infarcts, or even aneurysm in the future. Sarcomas can impact the mechanism of the myocardium, cardiac walls of the coronary system, as well as electrical conduction. Most of intramural primary heart tumors are asymptomatic, especially when they are small. Larger ones that are located close to large conduction pathways of the heart can constrict them and lead to the numerous arrhythmias and conduction disorders, including complete heart block or even asystole. For diagnosis, we can use echocardiography, transthoracic and transesophageal. Transthoracic echocardiography is better due to proximity to head, no interference with lung and bone, high frequency transducer with good resolution. Chest coronary with contracts and encasement and MR with contrast are superior modalities for delineation of the extent of tumor involvement in double-foot cases. Further suggestive of malignant cardiac tumors, large broad-based lesion accompanied most of the affected cardiac chambers, hilar lymphadenopathy, extensive pericardial involvement, hemorrhagic pericardial involvement, for definite diagnosis is mandatory. Less invasive methods such as cytologic evaluation of pericardial or pleural fluids might yield diagnosis in some cases only. PET scan useful in metastatic workup, and coronarography, angiocoronarography may be needed before surgery to know the feeding vessel to the mass. More invasive method of tumor biopsy through intravenous route, mediastinoscopy, or even thoracoscopy may be necessary to obtain a definitive diagnosis. A cardiac mass is defined as an abnormal structure within and immediately adjacent to the heart. There are three basic types of cardiac masses: tumor, thrombus, and vegetations. The first step to ensure it is not an artifact, a protein transducer selection, scanning technique, and evaluation from multiple examining windows will help to distinguish artifacts from actual anatomic structures. Experience really counts. And on this slide, you can see different diagnoses of cardiac tumors depend on anatomic structure. It may be left ventricle, right ventricle, aortic valve, mitral valve, pulmonary artery, and pericardium. Echocardiography is now the principal imaging technique for cardiac tumor detection. It can usually provide adequate diagnostic information such as cardiac site, size, and shape of a tumor. The clinical context in which the image was obtained is critical. The is movement of the mass and related structures during a motion image. Progression of an image over time may also indicate the pathologic process. If a cardiac mass changes in size from one image to the next, suspicion of a cardiac tumor is much higher. Knowledge regarding certain characteristic presentation. A specific type of cardiac involvement, the extension of renal cell carcinoma up to inferior vena cava, appears like a finger-like projection into the right atrium from the inferior vena cava. Uterine tumors also occasionally present in this fashion. Image myocardium and the cardiac chambers identified to presence of a mass and its mobility. Information about any obstruction of the circulation, whether the tumor could be a source or emboli. The sensitivity of echocardiography for transthoracic echocardiography in 93 to 97 for transesophageal echo in cases of heart neoplasms. Transthoracic echocardiogram is more often used in visualized atrial, and transesophageal echo is used to visualize ventricles. And on this slide, you can see the information about cardiac MRI and CT. I can, and on this slide, I can watch your most common type of primary cardiac tumor. It is myxoma. It is more than 50%, most commonly present in adults from 30 to 50 years and 65% in women. And myxoma cell can produce VECF. Majority of the patients with myxoma will present with at least one of the classic triad of obstructive cardiac, embolic, and constitutional or systemic symptom size. Obstructive cardiac findings: dizziness, dyspnea, maybe positional, cough, pulmonary edema, and heart failure. On EKG, you can show the enlargement of left atrium. Atrial arrhythmia and conduction disorder are rare, and CXR shows evidence of elevated the pressure of left atrium. Pulmonary edema is found in about half of patients with myxoma of left atrium, and echocardiography is the most commonly used modality for diagnostic purposes, and transesophageal echo is the preferred echo modality. 83% in left atrium and 12 occur in right atrium, and only about 1% are biatrial. Usually pedunculated tumors with a fibrovascular stalk attachment to the subendothelial base, and rarely cardiac myxoma can involve heart valves directly. On these pictures, you can see the myxoma and the mitral valve, and you can see the big size of myxoma. Size usually 4 to 8 centimeter in diameter, with maximum reported to 16 centimeters. Half of the cardiac myxoma have a smooth compact surface and half have a villar surface. Myxomas with a villar surface are more likely to embolize. Another tumor is papillary fibroelastoma. Is the third most common primary cardiac tumor, and fibroelastic grows distinct from lamp extrances and does not spontaneously regress, which may have focal calcification, clinically mostly asymptomatic. You can see on this echo picture. And the next slide, you can see that the transesophageal echo is the recommended imaging modality for the diagnostic for lesion measuring 2 centimeters or more. Generally appears as a round oval or irregular lesion well demarcated. 80 to 90% are found to the valvular endocardium, most commonly on aortic valve. The next tumor is rhabdomyoma, most frequent PST in infants and children, 80% in 1 year, but adult presentation also seen while rare. Spider cells are characteristic or regressing rhabdomyoma, and about to 90% of patients it is associated with tuberous sclerosis. 70% atrial origin and 30% ventricular. In symptomatic patient with arrhythmia, antiarrhythmic drugs may be used. Surgical exertion indicated in the drugs fail to control symptoms. No recurrence, and prognosis of the disease is excellent. You can see the CT and the cells of cardiac rhabdomyoma on this slide. Tumor features such as location, size, and means of attachment, as well as clinical context, are important clues to refining the different diagnoses. Although most masses are first discovered with 2D transesophageal real-time, 3D transthoracic may have an additive role into determining the potential etiology of a cardiac mass. 2D and 3D transesophageal echocardiography is of value in defining potential surgical approach wherever resection is planned. Thank you for your attention.